Melissa Memorial Hospital provides a diversity of healthcare services rarely found in a community of its size. The family practice of Holyoke Clinic employs 2 nurse practitioners and 3 full-time medical doctors, while serving a patient population that is largely paying via Medicare and Medicaid.
I facilitate the day-to-day operations. Obviously, clinic volume is always a priority, but we also strive for innovation. So we have quality measures. I make sure we're meeting all of our quality measures. We're part of an accountable care organization, or an ACO, and so we are always talking about how we can improve those, and really finding ways that we can help support our rural community with access to care, and expanding our services and meeting our patients where they're at.
I think we've got 2 good hospitals in our county. I'm 67, I got heart disease, and I don't want to live in a county that doesn't have good health care. And so it's important to me, and just as it is to many people in my situation, that we are 10 minutes from a facility like Melissa Memorial and the Haxton Hospital, that we can go get good care. And so it's huge.
I love the people here. I always appreciate our hospital. But when I came down with this debilitating disease, I didn't know that they could do what they're doing. And they're doing it times 10. It's just, yeah.
That's so great.
Yeah, it's been awesome. In spite of a horrible disease, it's been great. It's amazing because I do the PT here, OT here, and speech pathology here. And my disease obviously is going to get worse. But these dear folks, I'll go up there in this, on my quarterly visit with the ALS doctor, and of course we have that meeting where PT's there, OT's there, speech pathology's there, and I tell them what's going on. They said, well, sounds like they're doing a great job.
Most big hospitals don't even know you're just a number. Not out here, you're a name.
At the outset of the COVID-19 pandemic, the team at Family Practice of Holyoke established a telehealth program both to reach out to patients in their homes and to reach specialists in the Front Range via a dedicated wired room in the clinic.
Before COVID, obviously, rural health clinics weren't able to charge for telehealth visits. The originating site fee was huge, and so being able to provide that service to our general population for their acute needs, especially our elderly during COVID, they were scared to come in, and our providers were like, well, we still need to manage our patients. Obviously, we still have patients that have diabetes, have hypertension, they still need to be managed. Well, visits you could hold off for a little bit, but there's still sick patients that still needed to be seen, and so that really expedited our providers to onboard telehealth. We did it in about 2 weeks.
The outpatient clinic, the family medicine doctors, there is a lot we can do, and a lot of times we just merely need an expert's opinion on something. Maybe we're not asking the right questions, running the right test. If we can bring a patient in and have them talk to a doctor that's 3 and 4 hours away, who might ask the right question and give us a clue or recommend the testing that we need to do, we can do the groundwork.
Just trying to, rely on some of the newer technologies, the newer ways we have of trying to help these folks, get them in touch with the people that they need to, the specialists that they need. So just, having the ability to do that, and that we were able to set up, a dedicated space in the clinic with the high-speed connections, with the cameras, all of that, utilizing technology to kind of stay on top of that. I think that's been huge.
COVID was hard, but I think we're more resilient because of it, and we're actually more innovative. I think our quality of care has actually improved. We're actually increasing our quality metrics, and I think it's because we have better care methods and contact with our patients. We have more touch points now through this technology that I don't think we had before.
In a community of 2,500 people, Holyoke and Phillips County have a disproportionately high number of patients diagnosed with diabetes and other chronic diseases. To help manage this population, the clinic and hospital have implemented remote patient monitoring and chronic care management programs. Remote patient monitoring allows clinicians to electronically monitor and collect patient health data, while chronic care management aims to treat patients living with 2 or more chronic conditions, both when they are in the clinic and at home. After receiving a grant from the Colorado Office of eHealth Innovation, the clinic purchased remote patient monitoring equipment for 50 patients. The program is designed to keep clinic staff in touch with patients and to keep patients out of the hospital. Purchased equipment included the following: mobile hotspots and iPads, biometrics monitors, scales, and blood pressure cuffs. Patients spend 20 to 30 minutes per month conferring remotely with the chronic care nurse at the clinic, talking over care goals.
The chronic care management program really is a way for us in the clinic to help people manage themselves and their chronic conditions at home. So people have to have 2 or more chronic conditions, and then what I do is I do anything from go in and see them once a week to help with maybe medication boxes, or I do home visits maybe once a week, or sometimes some people just need a monthly phone call.
Number of patients, when we introduce the idea, they're like, I don't know if I want to do that. And once they step into it once, they go, this is good, and my numbers are getting better, and I feel better, and then they see the benefit of it, and fortunately they tell others. So word of mouth is important.
She can see a storm a-coming when she goes out there, and she comes back and tells me, let's do some blood work, let's, take away this medicine, let's add these medicines. She works with me closely so that we can do the best that we can for the patient.
This was huge for people who maybe they live 15 miles out of town and getting to the clinic is difficult. This really, really helps. Maybe they live in the town that's 20 miles away, but they doctor here. This helps them stay in touch with their practitioner and stay in touch with me, and it improves success rates for things. The goal of all of these programs is for me to help them manage themselves. I don't come in and manage them. The physicians aren't managing them. It's the person.
I'm really glad we're doing chronic care management, because if we can stay integrated with the patients, we're going to have better outcomes. We're going to have fewer acute visits and definitely fewer ER visits. And I will tell you, as a family medicine doctor, my goal is to keep my patients out of the ER and out of the hospital. That's really what I'm supposed to be doing. Now, there will be times where they have to go or they have to be admitted, but I feel like if I'm doing my job appropriately, I'm reducing the expense of visits.
We've had a couple of cases where we have detected something wrong with them because of remote patient monitoring, that had we not had that in place, they may have suffered a stroke or a heart attack, but because we had that in place, we were able to pick up an early sign.
He felt like funny feeling in his chest and did the biometrics monitor and saw that it was not right. That sent him to the ER to then get follow-up medical care. The goal is to keep people at home, and that's why we're doing the remote monitoring. But in that instances, we still counted it as a win because it caught something early enough so that interventions could be made.
Medicaid does not pay for remote patient monitoring or chronic care management. Medicare does not pay for remote patient monitoring for designated rural health clinics. Remote patient monitoring is not considered an RHC service by CMS. Often, the clinic is providing remote patient monitoring without being reimbursed at all.
I really wish that there was reimbursement for that, but unfortunately there's not because of us being an RHC, a rural health clinic. We don't fall into those windows like a metro area does. Like my chronic care management program is not available to people who have Medicaid primary, because Medicaid doesn't pay for chronic care management. They don't pay for transitional care management. They don't pay for primary care management, principal care management. So I do a lot of what I call pro bono work with those individuals. Okay, I still want you on my program because you still need help managing these things, I'm just not going to get reimbursed for it. The clinic is not going to get reimbursed for my hours working with that individual.
You can't just say preventative care is the only solution and not invest in it too, because it takes money to keep that person out of the hospital. It takes money to stay on top of somebody that doesn't manage their diabetes very well and try to convince them and build that partnership. The great thing is those tools help us build those relationships better because we are more connecting more often with our patients. Right now, this hospital is 5th lowest in the state for cost. So 5th lowest in the state for cost, and we're trying to do all of these innovative ideas. We need partnerships to be able to make those sustainable.
If I can save them a hospital trip, I just saved Medicaid thousands of dollars. If I can save them a clinic trip, I just saved Medicaid a couple $100s. It's that simple.